This meeting is being recorded.
So official. Okay, well, hopefully we'll get more people to join us here in a minute, but we will jump in and get started. I know it's a quick call today. We just have 30 minutes for our practice coaching call. We do have a little bit of education at the end of the call today. But for the most part, we're not going to do introductions. We're just going to kind of jump in. So this is the official welcome right now. We'll do a quick data presentation with Zainab. So thanks for being here, Zainab. And then we have a PDSA report out. So Dr. Lucine is going to do the report out. I don't see her on just yet. So we will just play with that when we get to it. And then we have a recorded presentation from Ronnie, who is our QI consultant for the project. So we will play that. And then we just have some quick reminders and next steps. So like I said, that's a quick introduction, and there's our team. And then I will turn it over to Zainab if you want to do the data presentation.
Sure. So this week, actually, we have some figures for metric 3. I am so happy to say that OSU has finally had access to their dicer splicer, and they've sent us pretty good data. So I know that if you have access to the previous slides, you can see that probably these numbers look a little bit different. That's because I guesstimated what I thought that their numbers would be. And so now that I have the accurate numbers, you'll see that there's some differences in April and May compared to what you saw in the previous slides from the previous months. So this one includes all the practices. This figure includes all the practices. As you can see, between May and June, we are seeing a pretty consistent vaccine completion rate, which is good. We're hoping to increase that, and compared to baseline, June is still not very significant, but like Dr. Crick says all the time, that metric 1 is a little bit harder to move, so it's nothing to be discouraged about. But this is just, you know, to allow you to see how far you're coming, and you know, if there's extra work to be done, then you know where that needs to be, where that needs to happen. I'm ready for slide 2. Okay, and so here is a figure of the OSU practices, all their metric 1 numbers. You can see that Lewis Center and Grandview had, or just Lewis Center has had a slight increase. And then Grandview and Hilliard saw a slight decrease from May to June. But Lewis Center and Grandview both had an increase since April. So that's good news. Again, here are just some values for you to gauge, you know, where you are. And if you have any questions, you know, please feel free to email me if you have questions about the data, or if you want to discuss anything outside of these meetings. I'll be happy to do that. There's no really a significant difference. And both Grandview and Lewis Center Hilliard has had a significant decrease from May to June. But again, because those numbers are very small, it's very easy to see a significant increase or decrease. So again, that's something to be significantly worried about. I'm ready for slide 3. Okay, and here we have data from all the pediatric practices, Augusta, Blue Ridge, Hilliard, and then Nationwide Children's. We are seeing pretty consistent vaccine completion rates in Augusta, Blue Ridge, and Hilliard, which again, like I said, those numbers are a lot harder to move. So being consistent is not necessarily a very bad thing. And Nationwide Children's, we have seen a significant increase in June compared to May. So yeah, like I said, if anyone has questions, you know, please feel free to stop me or to email me at a later time. I'm ready for the next slide.
Hey, Zaina, I'm so sorry. I cannot hear anything on this computer for some reason. I'm trying to play around to see if there's something I can fix. So I think you're saying move forward. So I apologize. I'm still playing around with it.
Yes.
But I'll move the slides. I'm sorry about
Okay.
that.
I'll just give you a thumbs up when I want you to
Okay,
move.
thank you.
Okay. I'm sorry. Can everyone else hear me fine? Oh, okay. And so here is a graphic of metric 2. We saw a significant increase. So this figure is for all the practices combined. We saw a significant increase from May to June. I guess it would be good to add that we have had one of the practices drop, so their data is no longer included in these figures. So metric 2 is the vaccine administration rate. And again, like Dr. Kirk always mentions in our meetings, that this metric is a lot easier to move than metric 1. So we see, we're not really seeing a very stable trend here. We are seeing movement. So it's good. It's an upward trend for now, which is a very good sign. I'm ready for the next slide. And so here's data from OSU. You can see all the practices in June had a increase compared to May. If you're looking at it from baseline, again, this is also something to know. Please, if you have questions about how to collect the baseline, then please email me. But here we are seeing, compared to baseline, a lot of them are pretty similar. We are seeing Lewis Center has a significant increase compared to baseline. But Hilliard and Hilliard saw a moderate increase, while Grandview saw a decrease. But overall, for the past few months, we have seen a relatively upward trend, which is a good sign. And I'm ready for the next slide. Okay, and here are the rest. Oh, these don't include June data for some reason. I'm sorry about that, but I will include the June figures in another slide, and I'll send that to Lori, and I'll have her forward that to you, Lori, if that's okay with you. Okay, so we're ready to move to the next slide. I think she's still having some trouble hearing me. Okay, and so this is the first time that we have some data for metric 3. It was very difficult in the beginning to have any data to plot onto a graph for you, because there was a lot of missing data from a few of you. But thankfully now we do have some pretty consistent data coming in. And we can see that the vaccine discussions are having also an upward trend from April to June. We are seeing a relatively larger increase as we move forward into the project months. So we are seeing an uptick in discussion and vaccine discussion amongst the practices. So that's also very good. Again, if you have any questions regarding any of this data that we presented, or if you're having trouble understanding your data specifically, then please email me. We can either schedule a call or we can discuss through email. Both work for me. So I think this is all we had for today in terms of data presentation. So thank you all. And I'm ready to give it over back to Lori.
Okay. Can you all hear me okay? I don't know what is going on with my computer right now. So I apologize. But thank you, Zainab. Hopefully you guys can hear me okay. So next we're going to turn it over. I think Dr. Lucine is on, and she's going to do her PDSA report out.
Hi, everybody. Lori, did you have the PDSA to put on the screen?
Yes, ma'am. And I can hear you now. So I think I stopped sharing and reshared. So now I should be okay. So there you go. Sorry about that.
So my PDSA this month was a little bit of a rolling trend from the 2 that I had done previously. So I love the rat cards. I don't know if anybody else has tried those, but parents really love them. They're colorful, and I just think they're full of good information. I have really latched onto those and started running. So hopefully, Lori, I can get more of those once the project is done because I love them. So what I decided to do this week or this month was to start introducing it more frequently at the 9, 10, and 11-year-old visits with the rat card, and then also using the cancer prevention language that many of us have talked about previously. In my office, we typically start talking about it at 12 for no other reason than at 11 we do Tdap and Menvio, and so 12 seems like a reasonable time. There's not a reason behind it. So I decided, after listening to many of you, I had been reluctant to start that early, just not knowing how it would be received. So that's what I decided to focus on this month. So I had my nurses just put the rat card in the room when they roomed the patients, when they did vitals and the intake. So that was my trigger to remember to do it. And we were kind of helping each other. I have a little sign up at my station that says, please hand these out to my families. So I really was not sure how this was going to be received. As I mentioned, I was a little nervous to start at that younger age, but after listening, particularly to Dr. Crick talk about how at 9, it just is like, it's a cancer prevention vaccine. So overall, I would say that what I observed that I wasn't expecting was that a lot of the parents were already thinking about this, that for most of my parents at 9 years old, they were not shocked to talk about it. They had already thought about it in their own families. And for the families who hadn't thought about it before, they were like, oh, okay, great, thanks. That's awesome. So I do think it was fairly well received. I did not get many patients to take the vaccine at a younger age, but I do think that starting the conversation earlier is going to lead to better vaccine rates in the future. So it was well received. Nobody yelled at me, which is always good. And generally the conversations were positive. So, so in that, it was overall well received, but I don't know that I moved the marker just yet. So I do think it kind of matched my expectations in that I didn't know what to expect, that it was partially positive, and I think will make a future change. So I do think I'm going to continue to do this more early introduction. And in fact, what I have started doing is having my nurses hand the card out at 9, 10, 11, and 12 if we haven't started HPV vaccination yet. That way we can have these better discussions in an ongoing manner. So I like the earlier introduction, and we'll see if it makes a difference in the future. I think it probably will. I think it's just going to take some time.
That's awesome. Does anybody have any?
So overall, I think that has been a helpful PDSA for me.
Great.
I put my comments in the chat, but this is fantastic. This is exactly what the PDSA is meant to do, which is to take sort of a big, overwhelming change and really needle it down to just something really manageable that you can learn a lot of information from. And I love everything about this. I really, really like that you're finding a lot of use out of that rat card. You got a ton of information just from this kind of small first step to let me see how well it's received. And really, you already have some pretty big plans on how to sort of move in the direction of really making, pretty enormous change. And I have no doubt that even if you never get to everybody gets it at 9 years, just this one step that you've already taken is going to improve your vaccine rate. So excellent job.
Yeah, wonderful. And thank you for taking the time to.
Great, thanks. Yeah,
Go ahead. Oh, go ahead. I'm sorry.
I just was just saying that I totally agree. I think it went better than I expected, and I do think it will move the marker over time.
Awesome.
Hi, everyone. This is Ronnie Christopher. I'm sorry I can't be with you today, but I'm super excited to share decision-making styles with you. The body of work comes from cognitive behavioral theory, and it's been used for decades to really try to understand what drives people's decisions on the things that they choose to or not do. And we'll apply it today in a healthcare setting around your HPV project. I've been a part of this project from the beginning, so I know what's been happening with all of you, and I'm excited to give you some of this information as I think it might be really helpful in your future and in improving your outcomes. And it can be applied to all of your patients, not just with your HPV patients. So let's dive right in. Decision-making in healthcare is really about like two things here. It's your personal values, who you are as a human, how you've been trained in your expertise, and how you bring that information forward to your patients to influence their care. And then the patient comes and shows up with their personal values. And in your setting, they might show up with their parent and guardian as well. So you have multiple decision makers here that you have to manage. You're managing yourself, you're managing your team's perspective, you're managing a parent and guardians, plus you're managing a patient. It's a lot to think about. Now, when we think about the decision-making styles a little more deeply, it really comes down to our clinical recommendations. So how we take our evidence and what we see in front of us, the information our patient shares, how we apply our clinical recommendations, and then how those land on the patient and the patient's parent or guardian, their right to make decisions about the information that we give them. When these things are in synergy, it works great, but when they're not, we can have some conflict or frustration. So there are basically 4 types of decision-making styles we're going to dive into today. There's principled, which are people who follow rules; virtue, which are people who like to make their decisions based on values; consequence, which are people who need to be able to weigh risks and benefits; and moral sentiment, which are people who make decisions based off of humanity. So principled decision makers, again, follow the rules. They believe in hierarchy. Laws are the highest order of their belief system, and they put a lot of stock in expertise. They're most likely to follow your recommendations, and so they generally are the easiest group of people to manage because you know where they stand, what they believe, and they usually follow through with a plan. So the pros here are they're clear and concise. They can be very black and white. They are generally reliable. They will follow up, they'll schedule, do all the things that you want them to do. They prioritize your perspective, and they absolutely follow the rules as you lay them out. The cons are that they might challenge rules if they're not clear to you. So they can come across as a skeptic if they think that you're not giving them something that sounds sound. They really like facts and logic. They may not share important information that would change a strategy because they're so black and white. You may not know what's going on in the gray space, and that might determine a different strategy you would take if you had that information. And then they can refer to other rules and not share those with you. They will absolutely prioritize expertise. So if they're seeing multiple providers, as an example, they might follow one provider's recommendations over another and not necessarily share that in between the providers. When we're influencing principled decision makers, we want to ensure that they understand the plan. This is a great group of people to use a say back method with. So tell me what you heard, John. Tell me what you're thinking, get them to say something back. That will allow you to understand if there's anything in that gray space they haven't shared. You want to give them permission to ask necessary questions, things that are important to them. So you might say things like, is there anything else that's on your mind? That's an open-ended question that would allow you to see if they're concerned or confused about something they haven't put on the table. And then you want to make sure they know what to do if the plan doesn't go as follows, because they like the rules. So they like to be, very well planned about what's next if something didn't go the way that you all had anticipated it to. Now, they're very different than a virtue decision maker. Although these two can sometimes sound similar, they are extremely different. The virtue decision maker is someone whose personal beliefs drive all of their decisions, and this can be founded in religious or cultural history. It doesn't have to be those two things, but often it is. They seek providers who share similar values, and options have to make personal sense to them. They're not necessarily interested in facts and figures unless that's a personal need. These are things that they feel, not necessarily think. And if they don't believe what you're saying, you have to try a different strategy. So the pros and cons with virtue decision makers are that they can feel really strongly and act accordingly once their decisions are made. They will absolutely follow the plan once they're on board with you. They generally have a really good support system. They like to surround themselves with people who think like they do, and they can be super passionate about their views, so you'll usually know where they stand. The cons are that they can sensationalize information sometimes, because if you come at them with logic or facts, they'll sometimes elevate a theory or a different perspective to make it sound as strong or viable to a fact. So that can sometimes create some conflict. That challenging from emotion can sometimes create some conflict, especially if you're not that kind of a person. They can make decisions that are not readily accepted within the norms, so they fall out of your bell curve sometimes. And they're very passionate about their personal views, which can also create conflict. That is a pro and a con for them. Influencing virtue decision makers takes a lot of skill if you're not a virtue decision maker. So we want to avoid bombarding them with facts, because it just creates more conviction in what they believe to be true. The more you hit them with facts, the more they come at you with, I don't believe that, I don't believe that, I don't believe that. So instead, we want to step away from that and ask for their perspective. We want to understand what's driving what they believe to be true. Is it fear? Are they unclear? Do they have apprehension? What are the convictions that are driving their decision making? Usually, when you can get down to whatever that is, you can figure out how to bring facts back into the conversation in a way that is actually beneficial. And then we have consequence decision makers, and these are our folks who really need to understand and weigh risks and benefits. Now, these are not people who are necessarily risk friendly or risk adverse. It's not about how much risk they're willing to or not to take. It's really about understanding risks so they can determine how much risk they're willing to take. They need a lot of information, and they need time to digest that information, and they'll generally stand by their decisions once they're made. But you're usually having multiple conversations with these guys because they really need to understand all the risks and benefits of something. So the pros and cons of consequence decision makers are that they're likely to paint an accurate personal healthcare picture. They usually give you a lot of information because they want you to know everything, so they can really discern like the pros and cons of something themselves. They're likely to investigate options with a broad lens. They'll engage in discussions about how you derive decisions so they can weigh what should be most important in their own decision making. And they can discuss risks and benefits with ease. So these are people who don't get anxious about a risk. They actually want to understand it so they know how much they're going to be willing to take it. The cons are that they might be frustrated with the process if they don't receive the information they're looking for. If they feel like you're being paternalistic, this will be very frustrating to them. It can delay their decisions, and that might make them indecisive, which can be frustrating to you. When you're influencing consequence decision makers, you want to use words like, we'll watch for this over time. We don't need to worry about this right now. Do you feel good about this decision? Now, I want to make sure that you understand this. We don't need to worry about this right now. You don't want to say that in a paternalistic way. That would really turn them off. You want to sort of weigh the risks with them. And so let's say that they say to you about getting a vaccine, I'm really concerned about getting a rash because I've had rashes before with vaccines and they were awful. And you might want to say something to them like, I don't think we need to worry about that right now. Because if that happens, we're going to go ahead and do this. So I think that is a minimal thing for us to be concerned about. So that's the way you kind of put that forward with this group. And then we have our moral sentiment decision makers. These are our humanitarians by nature. They're usually naturally concerned with everybody else's well-being, often in lieu of their own. They'll weigh decisions based on the good for all, not just themselves. They sacrifice their personal gain to benefit others all of the time. So the pros and cons for moral decision makers are that they value time with you and your staff. They generally have realistic expectations. They're usually very pleasant and often deferential, and they're often described as giving. The cons are that they can create a false sense of being okay. They might withhold information because they don't want to bother anyone or take too much time up with you. They might deprioritize themselves for the benefits of others. And so you might be thinking that you're trying to do everything you can for them, and they're sitting there the whole time thinking, well, I'll get all these recommendations later because I have to do something for someone else first. And when you're influencing a moral sentiment decision maker, you want to avoid closed-ended questions with them. You really need to avoid closed-ended questions with all of these decision makers. This group, it's really important that you avoid these closed-ended questions because you really need to understand how much taking care of everybody around them is more important than taking care of themselves. You also want to understand who is important to them. Who are the influencers in their own life? Are they deferring decisions to a significant other? For example, if you have a parent with a child in front of you and the parent is delaying the decision to get the vaccine because they want to weigh that with their spouse or significant other, you want to understand that, because really you need to get to the decision maker that is influencing them or that they're deferring to in order to help them feel comfortable with the decisions they need to make. And you want to help them build a sense of priority. So what can really be beneficial here is helping this group of people understand they need to put their oxygen mask on first before they put it on for someone else, using that analogy that we often hear on a plane. The idea of you can't be your best version of yourself to help others if you aren't taking care of yourself. That is often something that you need to reinforce with this type of a decision maker. So that's the 4 types of decision making. And our next steps here are to think about all these different styles and how they impact the patient interactions that you have. And you want to think about kind of a patient's particular style. There are telltale signs there. So you can see in your patient, a teenage or tween type patient, you should be able to tell pretty quickly one of these 4 styles within that patient preference. You also want to understand the parent and the guardian's decision-making style, because they aren't often the same, often very different. Then you also want to understand your own, and you want to understand your team's. So in these scenarios, 4 different decision-making styles could come into a very individual experience about getting a vaccine for a patient. And you could see that if you had 4 of all of them, if each person touching this patient, the patient themselves, the parent, the guardian, the provider, and the team, if all of you represented one of the 4 of those styles, there could be a lot of activity going on about whether or not to proceed with a vaccine. So understanding it up front can really help you think about how to influence it and have some interesting outcomes. So take time to discuss these types of actions that patients take when they exhibit certain styles as a team. I would encourage you, like during your lunchtime, to just pick a couple different patients who might be coming in with families that you know well, and see if you can think about what kind of style they have. Talk among yourselves about what kind of style you think that you have. And then think about how you might start to change or influence differently based off of these styles. I hope this has been helpful to you. I have shared this information with multiple practices across the country for several years. I've been doing this for many, many years. It's the one piece of information that I get requested to share often. And even today, actually had someone email me asking about decision-making styles. So I know that if you work it, it will work for you. So good luck, and I hope that you have a great rest of your week.
Awesome. I know that we are at time, but I did want to thank everybody for being on today, and thank Ronnie for recording that presentation for us. I'm sorry it jumped right in without any introduction. I didn't realize she would start talking immediately, and I've already had issues with my computer, so I didn't want to mess with it. So thank you guys for being patient with that. Just real quick, if you still haven't sent your goals in, if you need any help, that's what we're here for. So please let us know. We can provide any assistance you need for that goal setting. We don't have any other PDSAs due. So if you still haven't completed the 3 PDSAs or submitted those, please do as soon as possible so we can get credit for all of that. We do have one more data pull and one more practice coaching call in August. Then the MOC4 attestation is due in September with the final data pull as well. And then we do the sustainability data pull. So just as a quick note for your calendars upcoming. But that's all we had for today. I know it was jam-packed, but I appreciate you all being here on a beautiful, I don't know if it's beautiful in Georgia and North Carolina today, but it is here in Central Ohio at least. And Dr. Karras, hopefully it is for you too as well. We will be in touch soon, but please reach out if there's anything you need. And if there's anything missing, I'll be in touch with the practices to make sure we get everybody caught up. So Dr. Crick, Dr. Karras, I don't know if you have anything to close out.
I just wanted to say, I think you guys are all doing outstanding work, and I'm really impressed with the PDSAs and the progress that you're making, and keep up the good work.
Awesome. Well, thank you guys and have a great weekend.
Thank you.